Hey guys, welcome to the second episode of the PML podcast. Today's lineup, we're going to talk about some patient testimonials that have happened in the last few weeks, as well as the production that we just shot for the PML masterclass. Dr. O, which would you like to start with?
We're going to start with the patient testimonials. As you guys know, I've been in Longview, Texas for about 15 years. I came in from Boston, Massachusetts, where I did my orthopedic residency, as well as my complex spine fellowship. I give credit to two people, Dr. Bono, as well as Dr. Kirkwood, who is at Stanford University currently, and Dr. Bono is at Harvard University currently. We developed the PML technique, as you all know, about 2-3 years ago, and we have a lot of patient testimonials. We're going to share the testimonials in this podcast, as well as several podcasts down the road. But today we're going to talk about two specific testimonials. The first one, I'll call it a suicidal transformation to victory. So this is a 65, 66-year-old man, BMI of like 36, who presented to my clinic that he was having a lot of lower back pain. This is a man of God, goes to church every week, every Sunday, but came into my office saying, Dr. Al, I'm done. I can't do this anymore. My pain is excruciating. I said, what do you mean by you're done? He goes, I just want to get out of this world. So I asked him exactly what was going on, and he said my back just hurts. I know I'm overweight. I've done multiple injections. I've done neurotomies. They've burned the nerve. He's done physical therapy, and he said I feel like there's nothing else to do. I said, why don't we reassess and see if we can start with the minimal surgery, like a SI injection or SI fusion. So he said, what is that going to do? I said, let's just see what the SI injection does. The SI injection helps, then we can talk about options we have. Now, his problem, it wasn't just SI problem. He had scoliosis, adjacent level disease. He had previous back surgery as well. 40% of people that have had back surgery in the past have failed back surgery. Okay, failed back surgery is a well-known complication or long-term complication of extensive lumbar fusion. So he had the SI injection, and he got good relief, about 75% relief, but he also still had the lower back pain. So I told him, I said, hey, Mr. Blah, blah, I said, we can fix your back. I said, I feel like I can get you at least 50% reduction in pain. This man said, Dr. L, I don't think I want to have surgery. I think I'm just going to live like this. But just so you know, if I'm not here anymore, then that means I'm gone. So I told him, I said, bring your wife to my clinic next time. So the next time he came to my office, he came with his wife. His daughter is actually a therapist as well, occupational therapist. So she knows exactly, how to treat these patients, but her dad is complicated. So he shows up with his wife, and I sat them down. I said, do you believe in God? She goes, yes. I said, does your husband believe in God? She goes, yes. I said, your husband needs to show it when he comes to my office. I said, because I believe I have a solution for him. It's called the kickstand technique plus PML, which is a kickstand is a minimal invasive procedure that we use cobalt chrome rods to support existing construct, and then we link it and connect it to PML screws. So I told the wife, I want you to have your husband think positive and believe that this surgery can work. So eventually I convinced him to have the surgery. Again, this man is 275 pounds. He's done everything. He's given up on life. Surgery was about 3.5 hours. We did all minimal invasive PML screws, kickstand rods. Then, the first day after surgery, I went to see him on the spine unit. And I said, how's your pain? He goes, well, it seems to be fine. I said, sir, you go to church every Sunday. You have to think and speak positive over your life. And he said, okay, I'll try. And I told the wife, I said, every time I come in to see him around, he has to speak positive over his life. So every day I would go in and see him, and I would say, sir, tell me about the positive things you've had today. You say, I had a good physical therapy session, my pain is a little better. And the more he spoke positive over his life, the more positive results he got. So this man who had been suicidal, almost given up on life, comes to see us. Is about 9 months out. And so he left a great message for me and to the public actually on Facebook, and talked about how he's almost pain-free. It's not even a year since he had surgery. So almost pain-free means a huge reduction in pain, 90% reduction in pain. So you get a man that's going from I'm done with life to now he can't sit down. He wants to do stuff. So, I always tell people like, when I tell people failure, when you have failed in life, success is grand, it's huge. This man went from I'm done, nothing else can help me. Now he's in a positive limelight. He wants to like go out to go to dinner with his family, he goes to church, he stands, praise God. So that's the kind of stuff that I like to see. If this man had gone to another surgeon that doesn't do PML or doesn't do SI fusion, they would have told the patient, well, there's nothing really we can do. And then because he's overweight, BMI is over 35, some surgeons don't want to touch those people. But because of the minimally invasive nature of PML and the minimally invasive nature of kickstand technique with the cobalt chrome rods, this is a highly successful surgery. So I've done probably over 250 kickstand rods combined with PML. And we'll keep seeing patients like this that come in and give testimony. But that's the first one we got. And I wanted to share this with you and share with our patients that when they say, when you think there's nothing else you can do, you just have to find the right surgeon that believes in himself, believes in his hands and God, and believes that he can help you. And that's the first step.
And what is it about this particular patient that you saw, kickstand and PML was going to do the trick? Because I'm assuming a lot of people either took a look at him and said, I can't do the surgery, I can't help you. What about his situation? You were like, oh, this is where PML is going to come in. This is where I know I can do my very best to serve him.
Yeah, so kickstand has been something I've been doing for some time. I initially started with titanium rods. It was successful, but the stress on titanium rods are immense when you do kickstand rods. So I had a couple of patients that had the titanium rod actually break. It was a fatigue fracture. So I switched to cobalt chrome rods, which are more stiffer than the titanium rods. And I've never had a single cobalt chrome rod fail. And so someone like this that is almost 300 pounds, a BMI of over 35, he's had multiple back surgeries, that screws existing. I didn't want to take out the old screws. What kickstand does is it bypasses the old screw while you cement the new screws above the old screws. So this surgery is MIS. You lose about maybe 50 cc's of blood loss, as opposed to if you did a open revision, you lose like a liter. So the before I did this man's surgery, I'd done probably over 200 kickstand rods. So it just made sense that revising this man to kickstand gives him support. So kickstand gets you to stand up straight. But then you have to anchor kickstand to something. If you don't anchor it to the PML technique, then you don't have a solid construct. The PML gives you the foundation of the kickstand. So when I do kickstand, I would have like 3 PML screws, and then one of those screws will be attached to the kickstand. And that gives it the support that you need. So basically, you have a pelvic screw that's attached to the kickstand. Then you have 2 PML screws that protect the S2 screw. By doing that, it prevents that S2 screw, which is the pelvic screw, from failing because it reduces the motion across the SI joint. Before him, I'd done several, and patients will come in and give testimonies about how their pain went from 10 out of 10 to sometimes 0. So kickstand is a technique that I learned from New York. It's common in like tertiary institutions, academic institutions. There is a man called Dr. Alan Daniels at Brown University. He was one of the few people that I'd seen that used the kickstand rod. We use kickstand rods typically for scoliosis correction, and then I started using kickstand rods for scoliosis as well as to salvage previous back surgeries. So yeah, he was a good candidate. He, based on his knowledge and reading online about back surgery, he felt like there was nothing else to do. But because I had told him, he brought his wife, who is a huge anchor in the family, a huge rock, and I convinced both of them that this is minimally invasive. We're not opening your back. So you should get at least 50% relief. I didn't expect him to get 90%, but if a patient can accept 50%, then that's a good start. Then they'll be so happy with 90%. I had a patient one time tell me when they came to my office, they said, "Doctor, you lied to us." I said, "What do you mean?" She said, "You told us my husband was going to get 50%. I said, "Yeah." She said, "He has 100% relief." I said, "Oh, so you mean lied to us in a good way?" She goes, "Yeah." She said, "We never expected this much relief.
I'd be terrified if she said that to me, and I was like, oh my
Yes,
gosh.
when she said that, she's like, "You lied to us." I said, "What do you mean?" She said that. Initially I was like, "Oh my, did it not work?" She goes, "No, it worked more than we expected." So yeah, so that's this man. I have stories. I have several other stories about patient going from suicidal to like a new lease in life, and I still talk to them today. This man is a strong supporter of my journey in life. He's a huge advocate for me, and he thinks I'm the best thing ever. But I told him, I said, it's God's work. This wasn't me, but the fact that he trusted me to do this, I think it was a huge deal. Because if he didn't let me do it, he would never have known the benefits of the kickstand rod.
Now, question for the kickstand: are you still able to do it with the traditional method, or only would have worked with PML?
Very good question. Kickstand only works with PML.
Okay, why is that?
Because of the trajectory. Okay, so the trajectory of PML is the existing trajectory of an S2 alloy iliac screw. So we have a screw called the S2AI screw. It's the same trajectory of PML. So S2AI screw has been in existence for a while, but we never put it together to use as a SI fusion trajectory until I came up with the idea of, if we have an S2AI screw that's going from the sacrum to the ilium, so technically it's transfixing the two joints together, why don't we actually put a fusion screw that has porous coating and plasma spray that allows for ingrowth and ungrowth? So now when I do the pelvic screws, it's in the same trajectory of the S2I screw. So the S2I screw and the PML are in the same trajectory. If you wanted to do the traditional technique, you have to put the lateral to medial, but the lateral to medial head is on the outside of the pelvis. So if you cannot link a lateral to medial to a kickstand rod, not possible. So you have to do some form of S2AI screw or PML. So PML is unique. It's the only technique in SI fusion that gives you access to connecting to the kickstand rod. The posterior oblique lateral cannot do that. The lateral to medial cannot do that. The intra-articular absolutely cannot do that. The PML, the fourth technique, is the only one that gives you that opportunity, and it's seamless. You just connect it, you put the tulip, you can use a tower head, you can use a reduction head or a regular head. And the rod just slides in line from T10, wherever you start, all the way into the S2AI screw. And then you have the PML screws that protect the S2AI screw. There's a couple of studies now in the Journal of Spine and Spine Journal that talks about the benefit of the PML screw. They don't call it PML, they call it S2AI. But remember, S2AI screw is not a fusion screw. They are machined screws that are smooth. So there's no fusion going on there. Those screws can wiggle loose because it's not fusing. You have to put a 3D printed screw above it and below it to allow the fusion to take place. If the fusion takes place, it reduces the motion of the SI joint. If you reduce the motion of the SI joint, then it reduces the chance that the S2 screw comes loose. So there are a couple of papers that support this. It's something that I do all the time. If I do a pelvic screw from a T12 to pelvis, I'm definitely putting PML screws. And the S2 screws don't come loose. So that's something that every surgeon will benefit from learning, because you don't have to change positions. For the PML screws, addition to the pelvic screws, the surgeon stays in the same position the entire surgery. If you do lateral to medial, you have to go on the other side, and then the lateral to medial screws, the heads are lateral, so you can connect it to the existing rod.
So it seems like it's saving a lot of steps.
Yes, it's absolutely saving a lot of steps. It's saving multiple incisions that you have to do for the lateral to medial, and then it just makes it seamless in the sense that you're avoiding the SGA artery, the superior gluteal artery. You're still using the same incision that you're using for your surgery, and it's less soft tissue disruption because you're not doing multiple lateral to medial screws. And these screws connect to the rod. So it just makes sense to do it this way. So this guy that I did it that way. And that's why he's having 90% relief. I've done a couple of people like this same way. Even if you have existing PML screws, this is the only technique where if you have existing PML screws, let's say you have 3 screws on both sides, and you decide down the road that you want to put a pelvic screw instead, you can just take out one of the PML screws and just put a pelvic screw and attach it to the rod. This is the only technique. You cannot do this with lateral to medial. You cannot do this with intra-articular or posterior oblique lateral. only technique that allows you to, down the road, 10 years later, you want to take out one screw. You take it out, put a pelvic screw, same trajectory, and connect it to your rod. So that's the benefit. Now, PML has so many benefits. If I'm a surgeon, interventional pain physician, interventional radiologist, interventional spine, PML is something that I would want to learn because it will bring you rewards, not just financially, but just patient satisfaction, patient outcomes by not doing anything extra, but giving yourself a chance for success. That's the benefit of the PML technique.
And it's minimally invasive.
Yes, it's minimally invasive, fast, reproducible, less soft tissue disruption. If you just do the PML, let's say you don't even have a pelvic screw, like this man we're talking about. Let's say you were just doing a SI fusion. It takes about 30 minutes to do a PML. Bilateral, by the way. If you do a bilateral SI fusion using any other technique, at least an hour and a half. And some of those patients have to be admitted to the hospital because of the length of the surgery. For PML, bilateral SI fusion, they go home. We have a couple of videos on our Instagram that we showed the ease at which we place the screws. The incision is about 1 centimeter, sometimes 1.5 centimeter, but that's it. And you can place 6 screws. I've done 8 through a 1.5 centimeter incision, depending on the quality of the bone. Correct.
I know we just shot a production, so we actually got to see it live. So do you want to tell us about how that went? Because I know you mentioned that this procedure, or PML specifically, is reproducible.
Correct.
And that's the biggest and probably one of the most important factors in trying a new technique, or it comes to patients with severe pain, their ability to actually seek relief and get relief.
Yes. As a surgeon, I always want something that I can learn that is reproducible. One of my surgeons at Harvard, Dr. Burke, used to say, every day is always the same. So if you keep your system and your training and practice the same, it reduces your chance of complications. And it's absolutely true. So if I'm learning a technique, if it's reproducible, it absolutely reduces your chances of complication. PML checks all those criteria because I've done over 1,000 PML SI fusions. I've had like 75 to 90% reduction in pain on all patients. I've also done PML with pelvic instrumentation. Pelvic instrumentation, SI fusion combo, 75% relief. Without the PML, I can guarantee you that the S2 screw is going to come loose and their pain is going to skyrocket. So the PML screws protect the S2 screws. So when we did the class, we did an 8-module course, which is going to be available most likely January 1st. This course goes through everything you need to know about PML SI fusion. We talk about the pre-op expectation. This is dedicated to like interventional pain doctors, to interventional radiologists, to spine surgeons that want to know about the PML SI fusion. The beauty of this is I actually show you both the traditional technique, which is conventional lateral to medial. I also show you the PML technique. So when you look at this course platform, if you've never done SI fusion before, this is perfect for you because you get to see both techniques. You learn 2 techniques in one course, which is invaluable. The value of that is priceless. And then if you're comfortable with the lateral to medial, but you're worried about the vascular injury that occurs, then you can learn the PML technique. And the PML technique shows you the ease at which this is done compared to the lateral to medial. We don't worry about the vessel being injured. You don't worry about the multiple incisions if your BMI is over 35 because you have one incision. You don't worry about the weight-bearing status. The weight-bearing status is full weight right after surgery. The lateral to medial, they have partial weight for about 4 to 6 weeks. PML, no weight restrictions. So when you see this course, it goes from pre-op to like the day of surgery. We go over surgical instruments, what you need for the surgery, how your layout should be in surgery, where anesthesia stands, where x-ray stands. And then we have a 2-hour core dissection, surgical dissection of the cadaver, step by step of the lateral to medial as well as PML. And you can see the difference in the lateral to medial and the PML. It showcases both. So if I'm a new surgeon coming out of fellowship or a surgeon that's never done SI, then this is a perfect course for you because you can learn both. You can kill 2 birds with 1 stone, pretty much. And then it talks about the post-op expectations. We go over case examples, 10 cases, that we can dissect and tell you exactly how it's done. We show you post-op x-rays to show you how the PML worked. We tell you about the outcome measurement, the VAS score, as well as the ODI. And then we go over ethics and all the other things. So, and then we have advanced module, which is a POV, point of view, access to see what a surgeon is looking at, as well as step-by-step breakdown of a video analysis of a PML technique. So this is it's a great course for surgeons, pain doctors, interventional radiologists. You can watch it anytime you want because it's going to be on an app. So at home, if you're just at home on the weekend, you can just pull up your app and press on the PML technique. It's going to be an app, and then you can watch me perform the surgery. And then the more you watch it, repetition is key. The more you watch it, the more you get comfortable doing it. If you say, hey, I want to see Dr. live, we have a live in-person option as well, which you fly into Dallas. We have rooms for like 2 to 4 surgeons every time we do the course. And basically, this is live in session. I'll be there. I'll teach you step by step of the PML. I'll also show you the traditional technique just so that you have both options available for you. That's priceless. When you see me do the surgery, it's going to be cadaveric, so you can practice. We'll give you a copy of your video as well. So when you go back to where you're from, either in the United States or anywhere in the world, you get your video of your participation in the lab. So you can watch that at home. You can ask us questions by email. So this is going to be fantastic. We are all looking forward to it.
And they're also going to be able to ask you real questions as you're performing or demonstrating. So I know I had a million questions. I can only imagine what a trained professional / surgeon is going to probably ask you. I know all of our students that were there, they got to actually be hands-on and see the thickness of the bone and how hard it was to actually use a drill to go through. I don't think it went through because I think the bone was
solid. The SI joint is a solid joint.
Yeah, but I think that's fantastic. Is there anything out there resource-wise that's similar to this where you could learn about PML, or is there content that you've put out there, and where's the best place to see it?
So right now, since PML was invented by me, and there's not much content about PML out there except what I've put out. We have a paper in the Journal of Clinical Spine Surgery, one of the top journals in the nation, about the PML. It's called the Single Incision Posterior Medial to Lateral Technique for SI fusion. This paper has been well received. It was just published this year in the Journal of Clinical Spine Surgery. So that's a great resource. We have the PDF downloadable of the step-by-step technique. The good thing about the PDF downloadable is you can have it in the Word version, step-by-step, or you can have it in a diagram version. So both options are available from the downloadable. I do better with diagrams. So if you feel better with looking at diagrams, we can look at the diagrams. We'll have almost like what we call a cartoon, but it's not a cartoon, it's an animation version of the PML. You can watch the animation. Again, some of us do great with animation. I'm one of those people. It will show you the trajectory of the PML technique. We have post-op x-rays. If you go to my Instagram post, you will see a couple of post-op x-rays of the PML technique. So those resources will be available. I think we're also going to have, before you sign up for the course, we're going to have a couple of things available for free for all that are interested. We'll have the Module 0. We call it Module 0 because it showcases the entire Module 1 through 8. That will be available for you to just review and understand what the PML is about, even if you don't get the course. We want you to understand what PML is about. So if you don't want to get the course, totally fine. Now, we also have a preview, a separate free content on the preview of the entire course. So I go in detail of 1 through 8, what to expect, and then that gives you an insight of what the course is about. So I think those things are very essential for you to move ahead with the course, because the value of this course is probably about $25,000, and this course is being offered for way less than that. So just imagine a surgeon putting everything he knows out for people to learn. So we want people to learn a technique safely, reproducible, and less tissue destruction. So we are okay with offering this course, and we're comfortable offering this course less than the $25,000.
And I know we spent a pretty penny on production. I think well over that $25,000 just to get the didactics, the demo, the point of view. And I know the production team right now is working their butt off. We're basically making it look like a master class.
Well, it is a master
It
class.
is a master class.
Because I'm a Harvard trained surgeon. So when you go to Harvard, you're not just scaling through. You put in the work. And they don't take just anybody. You have to show them that you're worth their time. And I didn't just do that. I did that for the orthopedic surgery portion, and they also retained me for the spine surgery portion. So no, when I teach with everything I have. When I do surgery with everything I have. That's why I was the highest revenue generating surgeon in my hospital. I've done over 8,000 surgeries in East Texas, and I've done more than 2,000 SI fusions. I mean, literally more than any spine surgeon in the state of Texas, and probably number 1 or 2 in the nation. So when we talk about SI fusion, I can tell you without a doubt that I know the anatomy of the SI fusion, the innervation, the blood flow, the biomechanics of the SI fusion, the way it moves, what it doesn't do, what it does. So I think all that comes with experience. I know if you're screw, if you learn this, I've had surgeons send me emails about their screw trajectory and say, hey, doctor, do you think this screw is in the right position? I can tell by just looking at the screw if it is based on the length of the screw, the trajectory of the screw on the inlet view, and the inlet IR view. So you absolutely need IR views, and you'll see that in the course, on the AP view and in the inlet view. Because if you don't get those views, you can be mistaken thinking that your screws are adequately long enough, but they're not. You can also be mistaken that the screws are going into the teardrop, and they're not. So that's come with experience, and those are things that I share in the course, and I will share in the live in-person session all day. So that's why we talk about the value of the course. It's not unheard of for people to charge $30,000, $40,000 for these courses because of the amount of stuff that is involved. But for us, we want I want it to be a safe way worldwide for surgeons to do this surgery the same way. If you do it the same way all the time, the X-rays should look the same. If you don't do it the same way, your X-rays are not going to look the same. So your goal as a practicing surgeon is to make sure that your inlet X-rays and the AP view looks exactly the same. So if you look at my X-rays on my patients, the one we did in the lab, after an hour, 47 minutes of step-by-step teaching, my intraoperative X-rays at the end was exactly the same as if I did it in the OR.
Which is crazy.
Oh yeah, it is crazy, but like I said, it's follow the same steps. If you get the diagram alone, even if you don't get a course, you can have an idea what PML is. The diagram alone cannot give you enough confidence to do the surgery. The surgery has to be watched, rewound, watched, and then listen to me when I'm talking in the course exactly about the important things that you need to know, the angles, the special views that you need. So yeah, so you can get the free introductory stuff, and we have a lot of it, and we want you to learn as much as you can on why we're offering this course. But once you go through all the introductory stuff, we'll give you a feedback through your email, and then we'll let you know what else you have that we have to offer. Yeah, I think this is one of the few courses that has so much free content. We're not all about getting your information and having you charge your card. We want you to have enough information to understand the value of this course. Because a lot of people offer courses, and then when you get in there, they're not real courses.
Mindset, BS.
Exactly. It's not real courses, guys. This is a real course. This is a solution to a problem. This is not like maybe it is. I've done it. It works. We will have patients on this podcast that give testimony. We have written testimonies on our website. If you want to go to our website, we'll share the link on our website in the podcast. You can read the testimonials on there. So this is a real thing. And you have the guy here that's done the most PML surgeries than any surgeon in the nation. So I'm excited to teach this to surgeons. Some surgeons have egos. I get that. I respect that. But this ego should be left at the door because the more you do, this is one of the most profitable surgeries for you. It's fast, it's reimbursable, high reimbursement, it's outpatient. So if you have an ASC, all your patients go home. You don't have to keep them in house. It's a tiny incision. Infection rate is close to zero. I've never had to take a patient back for a washout after a PML. They can drive in a week. They can walk right away. There's no restriction. So some patients will come to me and say, "Doctor, I don't understand. I don't feel anything. I don't have pain." I said, "Yeah, that's the whole point of PML. There's no other technique that you're gonna do that you won't have some kind of pain, at least for the first 4 to 6 weeks."